It is my pleasure to introduce Dr. Atul Deodhar. Dr. Deodhar is an associate professor of medicine and the medical director of rheumatology clinics at Oregon Health and Sciences University. He has also been a member of SAA's Scientific and Medical Advisory Board, and he sits on the executive committee of Spartan, the Spondyloarthritis Research and Treatment Network. So Dr. Deodhar, I'm going to switch the reins over to you.
Thank you. And I'm delighted to be here for the very first webinar organized by the SAA. Can you go to the next slide, please? I'm going to do some general comments about ankylosing spondylitis. Major part of the disease progression occurs in the first 10 years of the disease, which is an important point to make. So if somebody has this disease for 20-odd years, and if you do not have the complications that I'm going to talk about, the chances of you developing new complications later on is not completely zero, but it is lower than if you had developed this complication at the start. A couple of studies have shown this. The study which I have quoted at the bottom talks about this, and what they found out was patients who ultimately developed heart disease or lung disease, the signs were already there in the first 10 years of the disease. Next bullet point, please. The bamboo spine, which is one of the dreaded complications of ankylosing spondylitis, occurs in a very small percentage of patients. And one of the studies, this particular thing comes from a study which was done in Brazil, a longitudinal study of patients, and they discovered that at the end of 20 years, only 20% of the patients had bamboo spine. Now, the difficulty, of course, here is what exactly is bamboo spine. Once somebody has got 3 or 4 vertebra involved, is that a bamboo spine, or you have to wait for 5 or 6 or 8 vertebra to be involved? So the definition of bamboo spine is kind of somewhat unclear. But again, the point is that not everybody who has ankylosing spondylitis develops the significant problems. Next slide, next point. There are several questions which I had here, which asked me about what is the difference between women developing ankylosing spondylitis and men. And so I have added 2 or 3 points in my slide so as to answer those questions now. Women seem to have more involvement of cervical spine and peripheral joints than men. Next slide, please. Next point. But ankylosing spondylitis in women has got no adverse effect on the fertility, pregnancy, or the fetus. Next point. Rheumatoid arthritis, we know pregnancy puts rheumatoid arthritis into remission. So women who have got rheumatoid arthritis, when they become pregnant, their rheumatoid arthritis goes into remission and they don't need any treatment. Ankylosing spondylitis, if you look at that, women with ankylosing spondylitis who became pregnant, there are studies which show that ankylosing spondylitis can become inactive or can flare or have no difference. So ankylosing spondylitis does not have a consistent effect on the effect of pregnancy is not on the ankylosing spondylitis. There is no consistent effect on ankylosing spondylitis disease activity. Next slide, please. Next point, please. Getting back to these differences between men and women, men have worse radiographic progression than women, usually in the studies, but the self-reported functional limitations are worse in women. And so this study particularly looked at women who were given questionnaires to fill out about their pain and stiffness. And even though the X-ray picture in these women looked different than in men, and they did have more peripheral joint involvement and more cervical spine involvement, their functional disability was more. And so that has led some people to believe that the peripheral arthritis, which is more common in women, might have led to the functional limitations. Next slide, please. This particular slide comes from Michael Ward, who is at the NIH, and he asked these questions, 7 greatest quality of life concerns reported by patients with ankylosing spondylitis. Now, we have received a lot of questions about the stiffness. It's very apparent that that patients with ankylosing spondylitis their biggest concern, even more than pain, is the stiffness. And the stiffness depends on several things. Stiffness mainly depends on the active inflammation that is happening in their spine. The stiffness also then later on depends on the actual vertebral spine, the spine getting involved in the inflammatory process and the new bone formation. What we were surprised at when we started using anti-TNF drugs in patients with ankylosing spondylitis was that patients who had apparently fused spine, whom we thought would not change, they actually said that their stiffness got dramatically better. Obviously, there were no changes on the X-ray, but the stiffness got better, indicating that major part of the stiffness, in fact, is related to active inflammation. So if we are able to control the active inflammation, even though people have syndesmophytes going from one vertebra to the other one, and the X-ray does show that there is a couple of vertebrae are fused, still the stiffness probably will get better because that is not directly dependent, or it is small, in a small percentage it is dependent on the X-ray radiographic problem. In bigger percentage it is dependent on the active inflammation. Pain, fatigue, sleep disturbance are the top 4 of the quality of life concerns. Worry about the future and medication side effects are lower down. Next slide, please. The prognosis of ankylosing spondylitis, and this is what I was saying about, is that if people, you can predict more or less the prognosis of the ankylosing spondylitis by when the patient presents for the first time, and this in a way tells you which patients to be aggressive with and which patients may or may not need the aggressive treatment. This particular slide shows some of the factors at presentation when the patient first presents, and these are the factors which indicate that the disease severity is going to be higher. Involvement of the hip. Now, hip is considered to be an axial joint. Involvement of the hip at presentation, the odds ratio is highest, 23. The higher the odds ratio, the higher the higher the severity of the disease. Sausage-like finger or toe, which we see in some patients with psoriasis and psoriatic arthritis, if seen in ankylosing spondylitis patients, the odds ratio is 8. Poor response to non-steroidal anti-inflammatory drugs. This is interesting in that rheumatoid arthritis patients do not respond to the non-steroidals as well as the ankylosing spondylitis patients do. There are some patients who tell us that these drugs, simple drugs like Motrin and Aleve, do not really help me at all, and that's a sign that the disease probably may be severe, and those are the people where I would quickly go on to the next stage of treatment, namely the anti-TNF drugs. High sedimentation rate, limitation in range of motion at the lumbar spine, oligoarthritis, which means 4 or less joints, peripheral joints involved. And again, remember that shoulders and the hips are considered to be axial joints. They are not really considered to be peripheral joints. So when I'm talking about peripheral joints, I'm talking about ankle or a joint in the hand or wrist or elbow or knee. 4 or less joints are involved. It is called oligoarthritis. The odds ratio is 4. And the onset of ankylosing spondylitis before the age of 16 would increase the odds ratio also. Next one, please. If none of these factors are present, the outcome is mild, and this has got very good sensitivity and specificity. Next one. If hip is involved or 3 other factors are present, severe disease is predicted with sensitivity of 50% and specificity of 98%. And again, I don't want people to get panicked about it, but then this would mean if you have any of these situations, then as a provider, I would go for aggressive treatment, more physical therapy, anti-TNF agents, experimental drugs, etc. Next slide, please. The next 2 slides talk about a study which was done from Europe. And this is to show about the AS burden of the disease. This is for percent of male patients, and the next slide is going to be percent of female patients with disability. And the Steinbrocker classification is divided into class 1, 2, 3, and 4. Class 1 Steinbrocker means that patient has got no disability and is fully functional. Class 4 Steinbrocker means that the person is wheelchair bound. So class 1 is no problem, class 4 is completely disabled. Class 2 would mean that the person is okay to day-to-day activities, but the person has difficulty in doing recreational activities. That's class 2. And class 3 would mean that the person cannot do recreational activities and has also had some difficulty in doing their day-to-day activities also. So this is looking at patients with mild to moderate disability. The blue lines show 11,000 patients with rheumatoid arthritis, and the orange bar shows patients with ankylosing spondylitis, 5,500 patients. And what it basically is supposed to show is that ankylosing spondylitis disability is as much as rheumatoid arthritis, even though previously people thought that rheumatoid arthritis, because it involves the peripheral joints, may have more disability. Next slide, please. The next slide shows the similar slide from the same study about female patients. And again, the Steinbrocker disability is more than 2. And again, it shows that the disability in ankylosing spondylitis is comparable to that of rheumatoid arthritis. On the x-axis is the age, patients below the age of 41 on the extreme left, and patients above the age of 70 on the extreme right. Again, the blue bar shows patients with rheumatoid arthritis. Here there were 38,000 women patients with rheumatoid arthritis and 2,400 female patients with ankylosing spondylitis. Again, the point that I want to raise here is that the disability is not less common in ankylosing spondylitis compared to rheumatoid arthritis. Another reason why SAA is pushing for more research and trying to cure the disease. Next slide, please. Early retirement in ankylosing spondylitis. Now, I'm going to show you, in fact, 3 studies, one from Netherlands, one from France, and one from Norway. Ankylosing spondylitis patients are 3 times more likely to become disabled compared to their age and sex-matched control population. So 31% of patients with ankylosing spondylitis were work disabled after 20 years, and 36% in the French study. Next slide, next bullet point, please. There was a study on 100 Norwegian ankylosing spondylitis patients. The mean age was 42 years, and the disease duration was 16.5 years. And about 26% of the patients were retired. So again, it's kind of coming back to this. At 20 years, about 1/3 of the patients, next bullet point, please, might show evidence of disability. And again, this graph here shows the red bar is for men and the yellow bar is for women, and the y-axis shows the years. There's the age at which this is the patients with ankylosing spondylitis got disabled. On the left-hand part of this graph shows the disease duration at retirement. So men became retired after about 15.6 years of age, and women retired just after 6.4 years of age. Now, this particular study has been criticized because in Norway, the government takes care of each and every person. It is easy to retire in Norway based on disability because the social security system is very strong. And in fact, somebody told me when I was discussing this study with a Norwegian doctor, he said to me that this is not going to happen in United States because, in fact, in Norway, it is people want to get retired and sort of get the pension early. So there is some kind of an incentive, in fact, to get retired in Norway, which is not going to happen. So again, I don't want people to get panicked about this. The retirement age is shown on the right-hand side of this particular graph, showing that men retired at the age of 43, women at the age of 36, which again gets back to the point that I made, that even though the axial arthritis radiographically is worse in men, the peripheral arthritis can be bad in women, and that might be the reason why women become disabled early. Next slide, please. We now are going to talk about the other disease manifestations in ankylosing spondylitis. What you're seeing is that some of this lettering is in yellow. Those are the common problems that we see in patients with ankylosing spondylitis, and the lettering in white, those are very, very rare. Melissa, you can just keep on clicking till we fill up these things. So if you click that, eyes, and the last one comes to heart. Yeah, so let's stop there. Let's go back one slide. I knew that this was going to come up. One more back. Oh, we need to go one more back. One more back again. Yeah. So these are the disease manifestations in ankylosing spondylitis. Eyes, let's start with the eyes. An acute anterior uveitis, which is a red, painful eye, not just a pink eye. About 40% of patients with ankylosing spondylitis usually experience a red, painful eye sometime during their course. This is one thing which we have made a lot of progress in controlling and treating. My own university in Portland, Oregon, has special interest in the research in uveitis. And the anti-TNF drugs are dramatic in controlling this particular complication. If you go down on the same side, the right-hand side, skin, psoriasis, and nail changes, up to 10% of patients with ankylosing spondylitis might have concurrent psoriasis and nail changes. So then it becomes a question whether it is a psoriatic arthritis with spine involvement, or is it ankylosing spondylitis with the skin involvement. In any case, these are overlapping diseases. If you go on the left side of this figure, it shows the heart, and heart can be involved. And I got a next slide. Actually, next couple of slides, I'll go into details about this. But aortic insufficiency, aortic valve, which is at the exit of the left ventricle, where the blood comes out from the left ventricle, goes into the aorta. The aortic valve becomes insufficient. It's also called aortic regurgitation, and the doctors can hear a murmur in these patients, or a heart block, which is conduction abnormality. This is seen between 3% to 10% of patients after 20 years of disease. Inflammation in the bowel is an interesting part. I mean, depending on which series you looked at, if you biopsy colon in patients from ankylosing spondylitis who may or may not have any symptoms whatsoever, at the colonoscopy, if a biopsy is done, between 20% to 70% of patients with ankylosing spondylitis may have microscopic changes to suggest some inflammation in their gut. About 6.5% have frank Crohn's disease, and we do have some questions here about concurrent having Crohn's disease and ankylosing spondylitis. And the treatment, the anti-TNF drugs, would actually help both these conditions simultaneously. Anti-TNF drugs, apart from changing the way we look at rheumatic diseases, have also changed the landscape of inflammatory bowel disease, and the anti-TNF drugs do significantly reduce inflammation in the colon as well as the inflammation in the spine. There are other things like dactylitis, which is shown here. Dactylitis is a swollen digit that you can see on the left-hand side of your figure at the bottom. Cauda equina syndrome on the right-hand side bottom, we are going to talk about that. Cauda equina is the end part of the spinal cord, where the spinal cord ends, and there's only a bunch of nerves which are coming out. That is Cauda equina. I'll talk about that later. Osteoporosis and osteopenia is not uncommon in patients with ankylosing spondylitis, and that is one condition we are going to talk about again a little bit later, which can cause fractures. Next slide, please. So this is the spectrum of ankylosing spondylitis. If you look at the columns, the first column talks about the symptoms, extraarticular manifestations, disease progression, and morbidity and mortality. In the early stages, the symptoms could be low back pain and stiffness for the symptoms. In the moderate stage, there is decreased spinal mobility, and most of this is because of stiffness. Again, part of this is because of the fused spine, and the patients may experience functional limitation, and in the severe situation, there could be fused spine. The extra-articular manifestations, there can be uveitis, gastrointestinal involvement in the form of diarrhea or abdominal pain, skin and nail involvement, or enthesitis. Enthesitis is where the tendon inserts into the bone, or the ligaments insert into the bone. That is called enthesis. And enthesitis is inflammation of that area. Itis, I-T-I-S, is inflammation. So enthesitis is inflammation of the enthesis. In the moderate stage, it is uveitis. Uveitis is the middle part of the eye gets inflamed, and these people have red, painful eye. That is what uveitis is, or iritis is also called. There is associated inflammatory bowel disease or psoriasis, and in the severe and the late stages, extraarticular manifestations can be restrictive lung disease, aortitis, inflammation of the aorta, heart block, Cauda Equina syndrome. What it doesn't say is also the kidneys could be involved in very, very rare situations with amyloidosis. And the disease progression goes from sacroiliitis, involvement of the sacroiliac joints, to going up and involving the spine with spondylitis, hip and shoulder involvement, peripheral arthritis, etc. The morbidity and the mortality, and I got one slide on this. These studies are old studies done in England about the mortality and morbidity, and the best study, in fact, is really old, where most of the deaths occurred because of spinal cord damage and fractures. And again, in today's world, in 2009, these are somewhat old data, and I will show you some new data about showing that the mortality certainly is not that dramatically increased. Next slide, please. Late complications of ankylosing spondylitis. Melissa, you can press another button, and this will be okay. So I have divided this into skeletal complications and non-skeletal complications. On the left-hand side, you see the late complications of skeletal complications would be bamboo spine, osteoporosis, extraordinarily important and usually missed, and we'll come to this, spinal fractures because of the osteoporosis. So this bamboo spine can be delicate, fused hips and shoulders, and fused ribs. And there was a question about the ribs fusion. Fused ribs at the back leads to reduced chest wall expansion, and that could lead to problems with breathing. Non-skeletal complications are heart, and we touched that earlier, aortic valve and mitral valve regurgitation or insufficiency. Conduction abnormalities, which is the heart is a pump, and the reason why our heart is pumping is because there is an electrical signal which is starting in one chamber of the heart and spreading across, and that electrical shock literally makes your muscle to contract. So that's called the electrical conduction. And if there is an electrical conduction abnormalities, if there's a problem in this electrical circuit, people can get heart blocks. Diastolic dysfunction, it is the contraction of the heart is called systole, and the dilatation of the heart is called diastole. Diastole is the time when the heart fills up with blood coming from the lungs, and then it pumps it out, then that is called the systole. So there can be, the heart can become a little bit fibrotic and somewhat rigid. That is called diastolic dysfunction. Very rare situation. In the lungs, there can be fibrosis, fibrous tissue, scar tissue generating in the top of the lung, which is the apical fibrosis, restrictive lung disease. In the kidneys, there can be amyloidosis, which is amyloid deposition in the kidneys, and neurological Cauda Equina syndrome and spinal cord compression. And we'll discuss this very quickly by one or two slides. Next slide, please. So the first is the aortic dilatation in ankylosing spondylitis. Aortic regurgitation is seen in 3.5% of patients after 15 years and 10% at 30 years, and is associated with peripheral arthritis. Next slide, please. Warning signs, and unfortunately there are no warning signs for this. So as I go through these slides now, this is kind of for practical purposes, in that how as a doctor or how as a person who has ankylosing spondylitis would you think that I may have aortic dilatation or something. And unfortunately for aortic regurgitation, usually it is silent. The only way I would know about this is when I listen to the heart of my patients. If there is a murmur, I mean, it's very obvious that the person would have aortic regurgitation because there is a murmur. One just has to be aware of this complication. What I do is I of course listen to their heart every time when I see the patients, especially if they got the disease for longer duration of the time. And for the conduction abnormalities, for the electrical abnormalities, it's as simple as feeling the pulse and seeing that the pulse is regular in the rhythm. If it is irregular, if there are heart blocks, if person is complaining of palpitations, that could be the sign that there may be an electrical abnormality, and that could be a sign of ankylosing spondylitis affecting the heart. Next bullet point, please. The treatment. So lots of treatments are available for this. If person has aortic regurgitation, there is a medical management, of course, and I'll talk about this a little bit in detail a little bit later. But in severe cases, one can do the valve replacement. Next point, please. Here is a cartoon of what an aortic valve is, and on the left-hand side, what you're seeing that AO is aorta, LA is left atrium, and LV is left ventricle. As you can see, the blood actually goes from LA to LV, from left atrium to left ventricle. This is the left side of the heart. So the fresh blood which has come from the lungs goes from left atrium to left ventricle through the mitral valve. And when the left ventricle, that V-shaped structure at the bottom, that contracts, the blood is thrown out in the aorta. And it shows this part of the aortic valve, the aortic cusp. And on the right side of this cartoon, of this picture, you see how in aortic stenosis, in ankylosing spondylitis, there is inflammation of the aorta and the aortic cusp, and it becomes deformed. And when it becomes deformed, this particular valve does not close properly. And if the valve does not close properly, when the blood is pumped from the left ventricle into the aorta, it can come back into the left ventricle. That is called aortic regurgitation. And if it is really severely affected, there is aortic valve surgery is done. But then if you catch it earlier, you can have some medical treatment to prevent its progression and treat the symptoms. Next slide, please. Conduction abnormalities, which is heart block, diastolic dysfunction, is seen in a very minority of patients. The number is less than 2 to 3% of patients with long-standing ankylosing spondylitis. Next point, please. Whether the changes are more common in ANKSPON compared to in general population is controversial. In fact, there was one recent study, Swiss study, it in fact found that there was no increased prevalence. This 2% to 3% that I quoted, they actually found it was less than 2%. And when they really did a careful study of looking at ankylosing spondylitis patients and age-matched controls, they found that these changes are not unusual in people who do not have ankylosing spondylitis. In those people, the changes have happened mainly because of atherosclerosis, not because of ankylosing spondylitis. Next point. Pulmonary manifestation, which is lung manifestations, is interstitial lung disease, which is scarring, upper lobe fibrosis, which is again scarring, and reduced chest expansion due to the fused ribs and restricted chest cage movement. So one of the things we monitor this is by asking the patient to take a deep breath, finding out their chest expansion. Next bullet point. So the warning sign, new onset of shortness of breath, new onset of cough, new onset of palpitation, missed heartbeats, and swelling on the legs. I ask these questions to the patient that I follow in my clinic, that since last seen have you had developed new onset of shortness of breath? I mean, all of us would get short of breath if we did unaccustomed exercise. But doing day-to-day activities, and the patient starts saying, I think I'm a bit winded when I'm going up the hill, or when I'm going up a couple of flights of stairs. I'm coughing a little bit. It's a dry cough. I got some swelling on the legs. I had this palpitation. Those are the warning signs for me as a physician that I would certainly listen. And of course, that they have got ankylosing spondylitis for a longer period of time. And again, the warning signs are there for us to catch this early and treat it aggressively. Next bullet point, please. And the treatment is available if somebody has significant problems with conduction abnormality. We can use a pacemaker. But the swelling on the legs and the atrial valve regurgitation can be treated with diuretics, which is water pills, vasodilators, which is dilatation of the blood vessels outside that can increase your cardiac output, and bronchodilators like patients use for asthma. That definitely helps with the shortness of breath and the cough. Next slide, please. Spinal cord injuries in ankylosing spondylitis are seen mainly because of osteoporosis. This is definitely common. Next bullet point. Osteoporosis is unfortunately missed in ankylosing spondylitis, and that is because if you undergo the usual bone mineral density examination on the spine, that can be falsely increased because of new bone formation. Patients who have got a lot of new bone formation and sclerosis of the margins of the bone. Sclerosis is the word used for suggesting that there is new bone formation. On X-rays, they look pretty white and dense bones. And then there are, of course, this new bone formation, the thin desmophyte, the part of the bamboo spine thing. The spinal bone density can be falsely increased. It is important for the doctor to understand and for the patient to understand that the femoral bone density, the hip bone density measurement is recommended to diagnose osteoporosis. Next bullet point. Patients with ankylosing spondylitis suffer spinal fractures at an increased rate with minimal trauma. And this is a worrying thing. A lifetime incidence is 4% to 18% because the spine is rigid. And if they suddenly stumble or they fall, there is a risk of trauma. And Laurie Savage talked about this. The FAA has produced a video because when these people fall to the ground and if they've got significant severe pain in their back, the first responders need to understand that even though they have a bamboo and rigid spine, that is fragile and that could have broken. And how to take care of this patient is a science which lots of ambulance workers may not know, and that's why FAA has produced this very important video mainly talking about the spine fractures and the trauma, and somebody found fallen down in front of their ground, asking the people, do you have ankylosing spondylitis, etc. Next bullet point. Incidence of spinal cord injury is increased more than 10-folds when compared to general population of Finland. Next bullet point. Compression of the spinal cord at the atlantoaxial level can cause. So atlantoaxial level is the topmost part of your spine. The atlas is the very first vertebra on the very top. So your skull is attached to this atlas. Axis is the number 2 vertebra. So atlantoaxial joint is the joint between the first and the second vertebra up in the neck. And the spinal cord is big at that particular point. It is coming out of your brain. It is pretty large. And a sudden jerk and sudden stumbling can cause a significant pain and compression of the spinal cord. This also occurs in rheumatoid arthritis, and it is well known in rheumatoid arthritis. It is not that well known in ankylosing spondylitis, but that can cause paraparesis, which is paralysis of the legs, or tetraparesis, paralysis of all 4 limbs. Next point. So the warning signs for fracture. This is what I teach my residents and fellows in my medical school, that you have a patient with ankylosing spondylitis who is doing fine, who is very stable, the patient is happy with the treatment, you are happy, it is pretty stable, the patient is functional, he or she is on the anti-TNF drugs. But then the patient says, I got this new backache. And then you have to quickly think about new backache, and you have been stable all along, and it's sudden and it is severe after a stable disease. That could be a sign of fracture. That could be a sign of fracture. And so that's why number 1 is, of course, one has to look for osteoporosis and treat aggressively. There are excellent treatments for osteoporosis, and one can clearly avoid fractures in patients if we think about it. Next bullet point. And the warning signs for spinal cord injury would be new onset sensory or motor symptoms, tingling, numbness, and weakness. The patient might come and say that, doctor, since I last saw you, I'm getting some tingling and numbness in my arms or in my fingers, or tingling and numbness in my feet. And that is a clear warning sign that there may be a spinal cord injury occurring. There may be a compression on the spinal cord, and taking action at that particular moment is one can avoid future complications. Next slide, please. Cauda equina syndrome in ankylosing spondylitis. Cauda equina is the last part of your lowermost part of the spinal cord, where the spinal cord itself has ended, and there is a small tail-like sort of a tail of nerves coming out. Neurological complications are overall rare in ankylosing spondylitis, only 2% of the patients. Next point. And Cauda equina syndrome is very rare complication seen in long-standing ankylosing spondylitis. Next point, please. It affects the nerve roots from the lumbar and the sacral spine at the very bottom. Next point, please. It may be secondary to the inflammation of the covering of the spinal cord. The spinal cord is covered into sort of like plastic sheets in a way. One is called the pia mater, P-I-A. The next one is called the arachnoid matter, and the third is the dura mater. And arachnoiditis is inflammation of this covering of the spinal cord. That's called arachnoiditis. So there is some kind of a controversy as to what exactly is the cause of the Cauda equina syndrome. What we do know is that the nerve roots in the lumbar and the sacral spine are affected. Question is it because there is a direct compression, or is it because there is inflammation in the arachnoid matter? Next bullet point. So the warning sign is slowly progressive pain and numbness in the saddle distribution. This is in the buttock region, where you would be sitting on the saddle. In that distribution, in the butt, if you develop pain and numbness, that could be a sign that the nerves in that area might be getting compressed, or there may be arachnoiditis, or the bowel and bladder involvement. And these are the signs of Cauda equina syndrome, that the nerve roots are getting affected. There are a lot of questions which have been sent by the members about peripheral neuropathy. And peripheral neuropathy, peripheral nerve involvement, is not commonly seen in ankylosing spondylitis. If the peripheral nerves are involved, they're involved as a part of this Cauda equina syndrome, or as a part of the neck involvement where the nerve roots might be affected coming out of these small holes in the spine. Next bullet point, please. Rarely muscle weakness symptoms are seen. Next point. Diagnosis of this Cauda equina syndrome. First, of course, one has to think about it. One has to keep it in mind that if my patient with ankylosing spondylitis is getting new onset severe pain in the spine, it could be fracture. Or if he or she is complaining of new numbness in the sort of buttock distribution or bowel and bladder complications, that could be a sign. Next point, please. And so there is treatment available, because if you do diagnose this with imaging with a CT or MRI scan, we used to treat this medically before by more sort of pain relieving treatment, etc., and physical therapy. Recently, a particular type of surgery is called lumboperitoneal shunt has been shown to be effective. And this particular paper is from Europe, and what they showed was the problem of Cauda equina syndrome is not because of a direct compression, because of a new bone formation there, but it is because of the arachnoiditis, inflammation of the arachnoid matter, the covering of the spinal cord. And they actually created a window, a sort of a hole, to reduce the pressure between that area by doing a shunt between that lumbar spine area and the peritoneum, which is in your abdomen. And that way they drain this excessive fluid in that area, relieving the pressure. And in their small series of, I think they had 15 to 20 patients only in that particular series, they showed that patients did a good recovery. Laminectomy, as you know, is if there is a direct compression on the spinal cord at that level, or the Cauda equina. Next slide, please. Mortality in ankylosing spondylitis. I got only two slides left. Mortality in ankylosing spondylitis is only slightly increased, and this is what I was telling you about, that some of the original papers claimed it was raised 2.3 times and 3.2 times, etc. But those were old studies. There is a lot of work done in this field to see the mortality, and it has been found that there is only slight increase. So if the general population is 1.0, this is 1.5 times the normal population. The cardiovascular disease, pulmonary disease, spinal fractures, and violence and alcohol, strangely enough, in the olden studies, which were the causes of mortality. Gastrointestinal bleeding, there are some questions which I'll answer a little bit later about use of non-steroidal anti-inflammatory drugs, and gastrointestinal bleeding can be a complication of the treatment itself. We did not talk about amyloidosis and the nephritis. Amyloidosis is amyloid deposition in the kidney. This is a rare complication, and this complication is directly related to the inflammatory burden. If you control the inflammation effectively, amyloidosis does not occur. So this is a complication of the past. And in 2009, if you're managed carefully, nobody should get amyloidosis at all. Colon cancer has been noted, interestingly, because that's somewhat surprising to me, because in fact patients with rheumatic diseases who take non-steroidal anti-inflammatory drug, colon cancer risk is lower than general population. Next slide, please. So in conclusion, this is my second last slide. Late-stage complications in ankylosing spondylitis can involve skeleton as well as internal organs. Next point. Skeleton is bamboo spine, osteoporosis. Next one, please. The skeleton, of course, has got then, of course, fracture of the spine because of osteoporosis. Heart is valve disease, conduction abnormalities, and the heart contractility is reduced. It's called the diastolic dysfunction. In the lungs, it is apical fibrosis, which is scarring, and restrictive lung disease because of fibrosis or scar tissue, plus the chest wall disease because of fusion of the ribs. Next point, please. In the kidneys is amyloidosis, which is directly proportional to the inflammatory burden. And my hope is that we are not going to see this, and I won't have to teach this to my students. Next one. Neurological system, the spinal cord injury, unfortunately, is 10 times more common, mainly because of osteoporosis and the Cauda Equina syndrome, which is very, very rare. Next one. Early detection by recognizing the warning signs is the key. We have got good treatments for all of this. These things do not occur in everybody, so there is no need to panic. One has to be aware of this and use these warning signs as the key for treatment. Next one, please. And all complications are treatable with symptomatic treatment as well as surgical treatment. Next one, please. The question, of course, that we have is, will anti-TNF agents prevent or treat these complications? And that remains to be seen. We do not know whether anti-TNF agents, and as I told you, most of the work that has been done about the long-term complication predates the anti-TNF agents, and we are, for the first time, these agents now are 10 years old or 11 years old. They first came into the market in 1998, and that had changed the whole face of rheumatology. And it's very exciting, and clearly what I expect is that when we are rewriting these papers, we are finding out that these drugs have really changed these complications, and most of these complications are only in the books, not in the real life. And the last slide, please. I just wanted to show you this patient of mine. His name is Keith, and he's a patient of mine for several years. On the left-hand side, you can see he has this typical ankylosing spondylitis. He's completely fused. In fact, he underwent a surgery to look straight because he was so much bent that he underwent a thoracic spine surgery to make him look a little bit straight. And he climbed Mount Hood. Mount Hood is the tallest peak in Oregon, 11,300 feet, actually, 60 miles east of where I'm sitting just now. And he has climbed this several times, which is outstanding. I mean, I cannot climb Mount Hood. I mean, I'm really frightened of doing it. It's technical. The last 2,000 feet from 9,000 on, it's very technical. You have to use crampons and ice axe and this and that. And this guy is absolutely amazing. And it just shows that with determination, you can achieve anything. And this person has got a pretty solid spine. We have been treating him aggressively for osteoporosis drugs, so that if he does take a tumble climbing these mountaineering or etc., he's not going to have a fracture. And so with determination, you can achieve whatever you want. Thank you very much for listening to me. I think Melissa is going to open it for questions and answers. And while she does that, I'm going to answer some of these questions which have been sent to me. Is that okay, Melissa?
Yes. Thank you so much for your presentation. So you should be able to see a questions pane in your control panel. And so if you do have a question, you can type it in and click send. I'm not sure how many we're going to be able to see today.
I have 12, 22, I got 25 questions here, which I'll quickly go through because I have touched upon most of those while I'm getting something from Lisa. So the first question, this is about the disease progression. There are lots of questions about women versus men. Can you discuss women versus men, and is it true that women don't fuse? And the answer is, I talked about that men do have more spinal disease. Women probably have more disease in the neck and in the periphery. But the fusion is not very different. So women do fuse also, but the peripheral joint involvement is more common in women. And that's why probably there is this perception that women don't have that severe disease in the spine. Most of my spine is fused and my back ribs are now motionless according to my osteopath. Do chest ribs fuse too? And I mean, this is kind of a tricky, but the thing is that ribs are only in the chest. So the ribs actually occur. Ribs start from the first thoracic vertebra, T1 to T12. That's where the ribs come. So ribs, there are no different back ribs or chest ribs. The ribs are in the chest. That's it. And so the ribs fusion, in fact, when it occurs at the spine, at the back. And so the motionless ribs, strangely, what we have found out is by giving these patients anti-TNF agents, their expansion of their chest improves. What we thought were fused are not really fused. It was mainly because of the stiffness and the inflammation, because clearly anti-TNF drugs are not changing the fusion. What they're changing is the inflammation. And so if somebody tells you you're completely fused, don't listen to them. If you're not on anti-TNF, you should try those, because it is astounding to me how much chest expansion can be improved in these patients. Fourth question, is AS considered, or third question, less severe if no fusion? True. If there is no fusion, AS is considered less severe. Does AS really burn out, or is that when you are fully fused? So we used to think AS burns out, and now we think that hardly anybody really burns out. Less than 1%. Less than 1% of the patients with AS are quote-unquote burnt out, where there is no disease activity. Even the patients who are quote-unquote fully fused have active disease. And this has been shown by 2 or 3 studies. One study which was done on adalimumab or Humira. They used that drug in patients who were thought to have completely fused. And there was surprising improvement in those patients in their pain, their stiffness, their function, etc. If feet are getting stiffer and stiffer, but both knees and hips, is this normal progression associated with ankylosing spondylitis? And the answer is yes. Getting stiff in feet, knees, and hips is part of ankylosing spondylitis. And again, the stiffness mainly is because of inflammation. Can you discuss related conditions, Crohn's disease, and does Crohn worsen with long-term AS? And the answer is Crohn's disease, Crohn's and ankylosing spondylitis together is seen in about 7% of patients, as I said earlier, and anti-TNF drugs would treat both. Peripheral neuropathy associated with ankylosing spondylitis, this is a common question. And there is no direct peripheral neuropathy. It could be a side effect of the medication, yes, or it could be because there is a compression of the spinal cord or the area where the nerve is coming out of the small hole in the spinal cord. So if somebody gets tingling and numbness, I would certainly consider peripheral neuropathy, but I would definitely look at the spinal changes, because that's what would be my worry would be that if somebody is getting a tingling and numbness, rather than blaming it on peripheral neuropathy, to look more centrally, to look at what is happening in their spine. The other 2 questions are similar to this. Are there any treatments for intermittent radiating pain and numbness in lumbar areas or lower legs? Yes, that could be meaning that you may have Cauda Equina syndrome, and this person would need an MRI scan or a CT scan to rule that out, and that can definitely be treated. Have experienced relief from Enbrel, but the progression of stiffness continues. Could that be because of old age arthritis? And that's really possible. Old age arthritis is osteoarthritis, and that can cause some stiffness, and the anti-TNF agents are not going to get that better. Somebody has asked about medication question about I've been taking indomethacin for ankylosing spondylitis for the last 12 years, supplemented by Ultracet when I have excessive pain. Is there any reason why I should move to Enbrel? And the answer is you can try. There are some specific guidelines which patients we try anti-TNF drugs. If you have got no pain by using indomethacin or Ultracet and you're completely normal function, then probably you may not need Enbrel. But if you continue to have pain and if you continue to have disease activity of more than 4 on this questionnaire called BASDI, Bath Ankylosing Spondylitis Disease Activity Index, then you may want to try Enbrel. My son and father have ankylosing spondylitis. My son is 22-year-old. He was diagnosed 2 years ago, has been asymptomatic on Humira for 9 months. I want to know how and when and if Humira should be discontinued. Great question. The answer is we don't know whether we can withdraw. What we know is if you do withdraw anti-TNF drugs, the disease mostly comes back. There are new studies in rheumatoid arthritis, not ankylosing spondylitis, in rheumatoid arthritis to withdraw the anti-TNF drugs and see whether patients can be in a drug-free remission. And we find that 30% of patients with rheumatoid arthritis can be in drug-free remission after 2 years. I do not know of any study in ankylosing spondylitis, but that is an exciting question, and I'm very excited that if you treat these patients early on, we might be able to put them into remission, a possibility, and then withdraw the drug and put them into drug-free remission for some time. This is my theory, but I don't really know about it. We have to do research on this. Does the use of, say, Enbrel and methotrexate for many years increase one's chances of conditions such as Bell's palsy? The answer is no. Bell's palsy has nothing to do with Enbrel methotrexate use, and personally, I never use methotrexate in ankylosing spondylitis. There are no studies to show that methotrexate has any role in ankylosing spondylitis. There are questions about I am allergic to anti-inflammatory medication and to Cymbalta. What help there is out there besides continuing Darvocet, water aerobics, and walking? And certainly, I would suggest to this person, if you're allergic to anti-inflammatory, you should certainly try anti-TNF drugs. If an AS patient gets gastritis, best options for non-steroidals, there are several options, proton pump inhibitors that you can take with non-steroidals for gastritis. There are drugs like the COX-2 inhibitors, which would reduce the incidence of gastritis, etc. Are there new medications other than anti-TNF blockers? And I'm going to combine that question with what does new genetic and other research tell us about the disease? And there are new medications. We are involved in a research project on a new drug, which is an oral pill. And all of these are biologics in a way, in that they are trying to reduce the cytokines, the TNF, the interleukin-1, etc. These drugs are going to be blocking TNF production. Currently, if you want to block TNF production, you have to take an injection. The newer drugs are oral drugs, which block the intracellular signaling pathway. This kind of sounds very complicated. But a cell, your ankylosing spondylitis is an autoimmune disease. Your immune system is your white cells. The white cells in the blood, that's your immune system. And the white cells, your immune system is making the TNF, tumor necrosis factor, usually to fight infection. In ankylosing spondylitis, the tumor necrosis factor, which is a chemical released by your white cell, that chemical is causing the pain and the stiffness. What the drugs do is they block this chemical. The newer drugs are actually going to act on the cell and stop the production itself. And that's where and those are oral pills. So those are not injectable, those are not IV. So there are a lot of new drugs which are called small molecules out there being researched. There are newer drugs which block T cells and the B cells, which are specific white cells. And we don't know whether they will be working in ankylosing spondylitis or not, but there are new research being planned to try T cell blockers and B cell blockers in ankylosing spondylitis. Should prednisone injections be used? And the answer is no. Prednisone does not work in ankylosing spondylitis. I avoid prednisone completely. It doesn't work. My hand and my tremors and numbness is getting worse. And again, this is I would worry about Cauda equina syndrome or a neck problem, etc. So one should definitely go to the doctor with this. I think I have finished the question that I have. Melissa, do you have questions for me?
I do, but we're running out of time, so I'm just going to ask you one or two, and then we'll
it is
conclude.
11:15,
Yeah. What are typical treatments for muscle spasms and neck muscles and rhomboid muscles?
Yeah, good question, actually. Thanks for bringing it up. There was a question here about Botox. So the muscle spasms, there are muscle relaxers, low-dose Flexeril, which is available. There are some pills which we use in fibromyalgia patients. Zanaflex, Zanaflex is another pill. Soma is one pill which we use for as a muscle relaxer. Low-dose amitriptyline is available for muscle relaxers. And thirdly, water therapy, the aqua therapy, water aerobics, warm water definitely relaxes the muscles and people feel dramatically better. So if you don't want pills, I would suggest aqua therapy, water aerobics, hot water therapy, and if you want pills, it is Flexeril, Zanaflex, Soma.
Okay. I think that's it. Let's conclude with that one. I appreciate you getting through. We had many, many questions. So, again, if you did not get your question answered today, please send your question to me at melissa.velez@spondylitis.org, and you'll see my email in your registration confirmation emails that you received to attend the webinar. So email it to me, and we'll do our best to have it answered. And again, please keep your questions general in nature, and because we cannot answer questions specific to your medical situation. Thank you so much, Dr. Deodhar, for presenting today.
Thank you very much. I mean, I enjoyed it despite the earlier glitches, but thank you.
Well, it's our first webinar, so, but we appreciate it so much. So before we conclude, I just want to remind you of a few things. Please complete the evaluation. You'll see in the slide that we have up now, you can get to the evaluation by going to www.spondylitis.org/webinar. You're also going to receive an email in about an hour with a link to the survey. And if you missed anything today, we have recorded it, and we're going to make it available in the member area of our website, spondylitis.org, early next week. If you're not a member of SAA, I want to encourage you to join us, and you can find information on how to join on our website. Joining SAA will give you access to our member area where you can find the recording of this webinar along with our monthly podcasts and the archive of our news magazine, Spondylitis Plus. So I want to thank you all for attending today's webinar and for bearing with us on our first endeavor. We hope to bring you many more in the future. So we hope it provided you with some valuable information, and we hope that you'll join us for the next webinar or seminar in your area. You can check back on the seminar and events page in the For Patients section of our website to find information about upcoming events. Thank you and have a wonderful weekend. Thank you so much, Dr. Deodhar.
Thank you.
Thank you. Take care, everyone. Bye-bye.
Bye-bye. Melissa?
Yes.
Hello?
Yes.
So are the other, is this been now muted for other people, or?
I'm trying to exit it now, right now.